Good morning, everyone. Thank you so much for joining us in our third day of Kidney Action Week with American Kidney Fund. We are so glad that you're joining us this morning, and hopefully the past couple of days you found the sessions that we've had for you very useful and informative. That's the goal of Kidney Action Week, so we're really happy that you're joining us today. I'm Melanie Paris, and my role at American Kidney Fund is Senior Director of Strategic Partnerships and Kidney Disease Education. And what I do here is to help make all of the education content that we have on our website, our outreach programs to people who are living with kidney disease. So, what we hope to do with those materials that we create to have resources available to people who are, like I said, either living with kidney disease or people who take care of people who are living with kidney disease. We've had some great sessions this whole week, and today what we're going to focus on are health disparities in kidney disease. We have an amazing guest. Her name is Dr. Anyamaka Inyanya, and she's going to talk about, unfortunately, some of the inequities that exist in kidney disease. And not only talk to you about those that exist, but we'll talk some more about what you can do to recognize some of those inequities and what we can do as a community around alleviating some of those inequities that we have around kidney disease. So let me introduce our speaker today. Our speaker today is Dr. Amaka Inanya. She is the Chief Transformation Officer at Emory Healthcare. She leads the transformation of patient, clinician, and community experiences by aligning and engaging key clinical and operational leaders on performance improvement. She is a board certified internist and nephrologist whose research interests and clinical experiences focus on patient centered care and health equity. Dr. Ananya, we are so happy to have you here today and look forward to your presentation.
Great. Thank you so much, Melanie, and to the American Kidney Fund for the invitation to speak today. I think this is a really important topic because, unfortunately, a lot of people don't know about the racial inequities that exist in the field of nephrology. And so I want to tell a story. I want to tell a story about how we, as the medical community, used a laboratory test for 20 years, right? A laboratory test that's been used to diagnose and manage kidney disease, and how that laboratory test in particular affected Black people. So, next slide. I don't have any financial disclosures. You've all heard where I work, so I'm not getting any additional funding from any other person that would affect what I'm telling you today or influence what I'm telling you today. Next slide. Let me tell you about why I felt, as a Black nephrologist and a researcher, why this controversy became very personal for me and why I decided to take it on. Because sometimes that's what happens in life, right? You get kind of thrown an issue or a circumstance that you really feel is like you were put on this earth to take that on. So I'll just start off by saying that I am a kidney doctor, right? I've treated and managed kidney disease for thousands and thousands of patients for many, many years. And so, I've firsthand experienced what that looks like for a patient, what it feels like to hear that they have kidney disease, and what it means to be on dialysis or to receive a kidney transplant. My family's also from Nigeria, right? And so a lot of this controversy around using race in laboratory tests has been focused on like ancestry, and is ancestry the same as race? And it's not, right? Race is a social construct. It was actually made up centuries ago, and I will talk about that a bit later. I also have people in my family that have kidney disease. So this laboratory test I'm going to tell you about affected members of my family directly in terms of the care that they received. I also studied sociology in college. I went to Cornell University. The Big Red was our mascot, Big Red Bears. And on campus, I looked at how Black students were discriminated against, right? And so very early on in my career, I was really thinking critically about race and what that meant and how that was affecting people and their behaviors and how they were treated. And then I went to a historically Black college, University, Meharry Medical College, which is in Nashville, Tennessee. It's the first HBCU in the South that granted degrees to Black physicians when they were denied entry to going to any other medical schools because of their race. And then lastly, I'm a health equity researcher. So for many years, I was trained to look at, patients, how they feel, their symptoms, the decisions that they make about dialysis, the decisions they make at the end of life. And so given all of these things that happened in my life, right, it just kind of felt like I had the knowledge, I had the skill set to take on a pretty big controversy and fight the good fight. Next slide. So in this talk, you'll learn about some of the disparities that exist in chronic kidney disease. And I'm going to focus on Black, Hispanic, and white individuals. That's where a lot of the data falls. I'm not saying that there's not other disparities amongst other racial groups, so that's what I'll focus on. And then I'll tell you the story of how we used race in this laboratory test to diagnose and manage kidney disease and why this was bad, why this was wrong. And then I'll tell you what happened since then, right? After fighting the good fight, what actually happened with policies, what happened to our guidelines in terms of how we use that laboratory test. Next slide. So let's kind of do a review of racial and ethnic disparities in the chronic kidney disease population. Next slide. So this is a graph that comes from our United States Renal Data System, and that is basically an organization that collects all of the patient data, all of the data for people who have kidney disease, who have dialysis, who have received kidney transplants. And so you can see on this graph, these bar graphs represent kidney disease, chronic kidney disease in the population. So on the far left, you see white individuals for 2010, 2015, 2020. In the middle, you see the same bar graphs for Black individuals, and then you'll see other racial groups kind of grouped together in that far right column. And you can just see that for Black individuals, those bar graphs are higher, right, than white individuals. And then the colors that you see represent the different stages of kidney disease. And so for more severe disease, we have this light blue. And for mild disease, we have the dark blue. And so for Black individuals in particular, they have more severe disease compared to white individuals. And so they have more kidney disease and actually more advanced kidney disease, meaning that they will progress to needing dialysis or kidney transplant more often than other racial groups. Next slide. So why is this, right? Why do we have these racial inequities in kidney disease for Black people in particular? Well, the number one cause of chronic kidney disease is diabetes, followed very closely by high blood pressure. Those are the number 1 and 2 causes. And people, after decades of research, still don't really realize how those diseases affect your kidneys, right? Because you don't really feel symptoms. And so people call it kind of the silent disease until it gets really bad. And then you feel, when you need dialysis or a kidney transplant, then you start to feel really bad. And for diabetes, Black individuals and Hispanic individuals have higher rates of diabetes compared to other racial groups. Black individuals have higher rates of high blood pressure compared to white individuals. And we find that the diagnoses of these diseases, high blood pressure and diabetes, are in younger individuals, younger Black and Hispanic individuals compared to white individuals. We also know that Black individuals are less likely to see someone like me, a kidney doctor, prior to starting dialysis. And all the research that has been published has shown that if you see a nephrologist early when you've been diagnosed, that is going to help prevent you from needing dialysis, from needing a transplantation, and even living longer, the earlier you get that type of specialist in your care. And so, with that being said, if you do develop advanced kidney disease or kidney failure that needs dialysis or a kidney transplant, we know that Black people are 4 times as likely to require dialysis or kidney transplantation, and Hispanic individuals are 2.3 times likely to develop those or to need dialysis or kidney transplantation compared to white individuals. So let's summarize. Black and Hispanic individuals have more diabetes and high blood pressure. They're less likely to see a kidney specialist before starting dialysis. They are more likely to need dialysis or kidney transplantation. And that last bullet says that Black individuals, given all of this disease, are less likely to be listed for a kidney transplant or receive a kidney transplant from a family member or a loved one. So tons of disparities. Next slide. So why is this? And this is really leading up to how, we used a laboratory test to widen these already long-standing racial inequities. A lot of people think that just being Black in itself is what leads to having bad kidneys. And again, I told you in the beginning of this conversation that race is a made up term. When we look at genetic studies, we find that genetically, Black people are actually more similar to, let's say, white people than they are to other Black people. So race is really limited to just superficial characteristics, your hair color, your eye color. That is the extent of race. And many years ago, race was used as a tool to basically say that one racial group was better than another. And that's where it started. So over the years, in medical curriculums that were developed, it was like Black people are worse, right? Like they're just naturally born with disease. They're naturally born with different physical characteristics, larger skulls, thicker skin. And you can really trace that back to slavery, that Black people were seen as just kind of brute and strong and just naturally bigger, right? But again, all false. Nothing has ever proven that the way that you were born into a certain race leads to you being physically different. Okay, let's get back to the disparities. So, what is causing the differences that we see in kidney disease and high blood pressure and hypertension? Well, this graph is really a way to just show you that it's all linked to the social determinants of health, right? Where we live, where we work, where we grow. That is how the World Health Organization defines social determinants of health. So, do you have safe housing? Can you afford healthy and nutritious foods? Do you have health insurance? Are you being exposed in your neighborhood to pollutants that will affect your body? What kind of foods are you eating, right? So imagine if you don't have safe housing, you can't afford food, what kind of lifestyle decisions are you going to make that could really negatively or poorly affect your organs? So if you're eating a lot of processed meats or sugars that are high, or foods that are high in sugar, you're going to have poor control of your high blood pressure, poor control of your diabetes. That is what is leading to racial inequities, right? Not that you're born into a certain kind of physical body, but it's the structural racism that has been caused by society kind of putting people in different areas, right? Living in certain neighborhoods, affecting the type of job you can get, how much are you getting paid? Those things track very closely with race. That's why race is a social construct. And so those are the things that are causing lifestyle changes, that are causing high amounts of stress, dealing with racial discrimination. That is affecting the kidneys, not how you're born. Okay, next slide. So let's talk about this lab, an EGFR equation. So that's what the lab test is called. It's EGFR. So if you ever get your labs back from your primary care physician, that is the test that I'm talking about. Next slide. So imagine that two people walk into a kidney office, my office, a kidney doctor's office. You have a Black person and you have someone that's not Black. They're both the same age, the same sex. They both have the same laboratory value that we use to see how well the kidneys are working. That's called creatinine. But they both have this different laboratory test, and that's really a calculation, the EGFR calculation. You can see for the Black person, it's 47, and for the non-Black person, it should be higher, or it should be lower for the non-Black person. That's an error. Let's just say it's 42. So based on these four things that go into the equation, age, sex, creatinine, this is what and your race, this is what determines how different your lab calculation or EGFR is. And the way that we explain EGFR is how well your kidneys are functioning. So if your EGFR is 47, we say that your kidneys are working at about 47%. So for a Black person, based off of skin color alone, this laboratory said that Black people had better kidney function than a non-Black person. Let's just imagine that that number is 42 on the screen. And again, the only difference is skin color. Next slide. How did we get here? So 20 years ago, there was a research study that developed this EGFR laboratory equation. And what they found, what was really strange, was that for Black people compared to white people, they had higher levels of this serum creatinine, again, the biomarker that we use to see how well people's kidneys are working. So for both men and women, this solid line on the top shows a higher creatinine level than white people, this dotted line. And in the study, the researchers were like, oh, that's interesting. Why don't we develop a Black equation that's separate because their creatinine is different? And then we'll just use a different equation for all other racial groups. And that is how we got two different EGFR equations, one for Black people and one for everyone else that's not Black. Next slide. What is the downside of doing something like this? So we've already talked about the inequities that already exist in kidney disease. But if you're a Black person and the EGFR equation is saying that your kidney function is better, well, that's going to delay your care, right? Because we have guidelines that say you should see a nephrologist when your laboratory value, your GFR, is less than 30. So if a Black person compared to a non-Black person has a higher EGFR equation, that primary care doctor may just hold on to them until that lab equation actually is low enough to see the doctor. Same thing for being listed for a kidney transplant. We have national guidelines that say that you actually can't be listed until your EGFR number is 20 or less. Again, a Black person compared to all other racial groups has a higher EGFR equation, which is saying that their kidneys are healthier, so they have to wait longer to get listed for a transplant. This also is a delay in terms of preparing for dialysis, getting educated. We have guidelines to say when someone should actually start receiving that education, when they should start preparing for that dialysis treatment. We also don't have a way for mixed patients, right? Patients of mixed race and ethnicity. Which equation do you use? What would you do if Barack Obama came into that office, or Kamala Harris, vice president, came into the office? Which one do I use? There's only two, Black or not Black. So there's really no way to treat someone who has 2 races, 3 races, 4. How do we treat them? That's unfair. Also, if Black people are having higher EGFR equations that say that their kidneys are working better, well, they may get drugs that are stronger for their kidneys, right? Because we're saying that their kidneys are better than everybody else's. So they may be getting harmful doses of treatments and medications. And lastly, this is really not transparent. For 20 years, I'm sure if you ever have, been to a kidney doctor or a primary care physician, people weren't telling you that there are 2 equations, one for Black people and one for not, for other racial groups. That is a real violation of how we practice medicine. We need to be transparent with how we're making our clinical decisions. And for 20 years, we were not being transparent with the majority, or if not all, of our patients when we talked about timing of treatment and referrals to specialists, et cetera. Next slide. So what does this also mean in terms of the kind of bias that can cause, right? I've already talked to you about how slaves, Black slaves in the United States were seen as kind of big and brawny and stronger, right? And so if you have an EGFR equation that's saying that Black people's kidneys are just better, how is that affecting your care, right? First of all, you're judging somebody by their skin color. That is an explicit bias. That is, you're thinking about it, a conscious and controlled act of choosing a different equation for someone who's Black. That is bias. But what about the implicit bias, the unconscious biases that we all have? How does maybe thinking that somebody's kidneys are better, that people are stronger, right? How is that going to influence a doctor's care or a nurse's care? How is that going to affect the medication that you choose, or when you send somebody to a kidney specialist? We actually haven't studied it, but based on other different types of medicine, like OB/GYN care and other types of studies that have been done, implicit bias negatively affects specifically Black people in the United States. So we haven't studied it in nephrology, but it's probably not good. Next slide. So let me talk to you about what has happened since this controversy of beef fighting the good fight, right? Doing a lot of talks. Next slide. I use social media to help me out because there was a ton of powerful people, and there still are to this day, that did not like us getting rid of this EGFR with Black race equation, right? They thought it was like not scientific and that we were being sensitive. And so many people, journal editors, chairs of departments, even some policymakers, were really having a lot of resistance. So I use social media. I made some TikTok videos. I used the media, the New York Times, and all of these other media outlets that just got the word out there. And when the word got out there, people got mad. Medical students were enraged, right? I did an episode of Grey's Anatomy. I helped Shonda Rhimes' team write a story about this. They aired that episode and people got really upset. So I use the media as a tool to get this information out there. Next slide. What else happened? So, okay, all of this information is out there. The newspapers are writing about it. Grey's Anatomy is showing an episode. So what happens? Our two largest kidney societies, the National Kidney Foundation and the American Society of Nephrology, brought us together for a task force to focus on reviewing all of the research and talking about how we were going to make this problem right. On this task force, there were specialists from different types of medicine. There were chemical lab people on there. But what was most important were that there were two patients that experienced kidney disease that were living with it. And that was actually the most helpful piece of having this task force, because you can imagine a lot of ego. There was a lot of people not agreeing on next steps. And so, the patients really brought the ego down in the room. And we talked about this for over a year. We met for hours every week to talk about how we were going to do the right thing. Next slide. So what we ended up doing was, number one, having national guidelines that basically said that we had to use a new equation, a new research study that I was proud to be a part of, that said that everybody should use this one EGFR equation. There's no race attached to it. It works just as well as the old equation that had race in it, but we can use it for everybody, and everybody's kidneys will have that same EGFR number instead of having, again, one for Black and one for everybody else. The other thing I was a part of were some federal policies that also came out. The first one in 2022 that said no kidney transplant center could ever use a race-based equation, EGFR being one of those equations, to list somebody for a kidney transplant. Again, making sure that everybody has equal access to being listed for a kidney. The other federal policy that came out last year, and this is the one I'm most excited about. I called it the reparations policy. But essentially, all of the U.S. transplant centers, kidney transplant centers, were required to review all of their Black patients who were on the wait list. And if they had used a race-based equation to get onto the wait list, that had to be modified and people got wait list time back, Black people. So we did an analysis of the first 6 months of that policy, and 6,000 Black patients had their wait times modified, meaning they had additional time added back to the wait list. The average time was 1.7 years added back. So people went from the bottom sometimes to the very top. And that resulted in 506 Black patients receiving a transplant last year. And that's not even the full analysis of 2023. We're still waiting for the full analysis. And so there'll be more numbers to come that will be shared shortly. Next slide. I also want to just make a note that history repeats itself. And I'm sure many of you are seeing in the news this attack on diversity, equity, inclusion. They're trying to pull it out of curriculums, right? They're trying to have state policies that you will be penalized if you put that into your schools. Well, the same thing is happening in medicine. And in 1968, there were some guidelines that said that Black people should get more radiation for x-rays, for dental x-rays, for any other x-rays. And they were getting sometimes up to 40 to 60% more radiation than other racial groups. Again, this was based on false and racist notions that Black people had more bones or stronger bones and needed more radiation for people to see, right? For the doctors to see the actual x-rays. And the biggest resistance came from the medical community, from the scientific societies, right? And so it really was taking a lot of consumer activism to make this change. And so we're seeing that right now. The resistance is still pretty high. A lot of institutions haven't switched to the new equation. You can all look up your labs and see, when you look at your EGFR equation, does it say Black on there or is it just one? So you can see for yourself in your own institution, have they made the change? And I would encourage everyone to ask their physicians, why have they not made the change if you still see that there? Next slide. So in summary, health inequities in kidney medicine or nephrology have been long-standing, but we know that that is not caused by how you were born, but from systemic racism that has caused inequitable access to housing, to food, to insurance, that is causing different lifestyle changes, different stresses on the body. That is what's causing higher rates of diabetes and high blood pressure and poor control of those diseases, leading to more kidney disease. We also know that the misuse of race in science based on these false notions that Black people are biologically different have really done nothing good but promoted bias and widening the already long-standing health inequities that we see. And we know that it really is going to take clinical guidelines, federal policies that ensure that the wrongs of the past are made right, and that these changes are made to stay going forward. So I hope you all learned something new today, and we will take questions.
Thank you so much. That was very enlightening. And, I've often heard the term health equity and health disparities a lot, but your presentation really helped to bring down, like, what does this really mean on the ground for people who are living with kidney disease? It's not just a concept. It's not just something you read about in a book. These can affect real people in really critical ways.
This is correct. Yes.
So there's a question that kind of relates to something very practical in that way. One question that came through is, you talked about Black patients getting to kidney failure more often. And the question is, how can I prevent getting to the later stages of kidney disease? And I think maybe in the context of what you were talking about in terms of these racial disparities that are very much present, what can someone do to make sure that they are not getting to those later stages?
That's a great question. So number one, I would encourage everyone to make sure that they have good and consistent follow-up with the doctor, whether that's a community center or a clinic. You're going to need someone that can check those labs and make sure that you're doing okay. The other big thing is that the control of the diseases that are causing kidney disease, diabetes, and high blood pressure need to be controlled. Every single year, I had numerous patients that say, I feel fine. I don't need to take my high blood pressure medications. I don't really need this insulin. I feel great, right? Not knowing that those diseases are the ones that are beating up your kidneys 24/7, right? And so the best way to ensure that you don't progress to later stages of kidney disease are to control the diabetes and the high blood pressure, healthy diet, staying hydrated. All of the healthy things that are good for your body are good for your kidneys.
Thank you. Can you maybe talk a little bit about the structural racism and disparities, and kind of contrast that with some of the things that we're hearing about in terms of genetic causes? Like, is there a difference there? How do people start to think about, in terms of, a genetic condition versus the structural racism that you're talking about in kidney disease?
Yeah, that's a great question, and it comes up often. I think again, we've been educated that race is a genetic construct, that it's a genetic thing, but that's not true. And there was a big study that was published in 2003 called the Human Genome Project, which looked at thousands and thousands of genetic information for different peoples across the globe, and they found that the genes weren't the same in all Black people, right? Like, so Black people genetically didn't look like each other. Black people looked like other racial groups genetically that were actually more different within our racial group compared to someone who's outside of our racial group. So we can just throw that out the window. Now, genes are very important, right? There are genetic diseases. I want to make sure that there's clear kind of communication that there are some genetic diseases that can cause you to have kidney disease. And those things are actively being studied to see what type of new therapies can be used to treat those genetic disorders. But the structural racism is the largest reason why we have the inequities that we do in kidney disease, racial inequities that we do in kidney disease. So again, when I talked about having access to safe housing, or being able to afford food, or having insurance, or living in a neighborhood that you can walk and get exercise, that's safe enough to do those things, those are the things that are leading to your lifestyle changes. What kind of food do you eat? Where are you getting your produce from in the grocery store in that neighborhood? Those are the things that are contributing to the lifestyle changes that we see that can affect your kidneys, not genetics.
Thank you for that. Because, we hear a lot, okay, this runs in my family, something like diabetes, which can, and hypertension. So if you say, well, this just runs in my family, I have diabetes, doesn't that make a difference? How does structural racism make a difference if it just runs in my family?
Yeah, that's a great question. So, again, diabetes and high blood pressure can run in your family. It's the control of those diseases that will influence your kidneys and how healthy they are. So, you can definitely have genetic reasons why you have more diabetes in families or more high blood pressure. I have that in my family. So, I have to be very careful to control my blood pressure, to make sure that I'm going to see my doctor on a regular basis so I'm not developing kidney disease, because I know it runs in my family, and I know that my blood pressure also, high blood pressure also runs in my family. So I have to be really proactive about my care to make sure that I don't develop kidney disease, because that is exactly what happened to my family members. They had high blood pressure, it wasn't controlled for many years, and that's how they got kidney disease. So I'm always checking my blood pressure, always going to the doctor to make sure that I myself don't end up with kidney disease, because I have that genetic history of people having high blood pressure in my family.
So what I hear you saying is that in many cases, not all, but if something runs in your family, it doesn't mean that you have to get it yourself, but often there are things that you can do to make sure that you don't get it in terms of prevention, testing for certain conditions, like your blood pressure, often your blood sugar, making sure that you're eating well and getting enough movement.
Exactly right. So, like, for instance, my brother, right? Again, it runs in my family. He works out all the time and he has high blood pressure. So, again, he knows that kidney disease and high blood pressure runs in my family. So, he got on the medication immediately. Young guy, very fit, but he doesn't want to end up needing dialysis like some of our family members. And so, he controls his high blood pressure by taking his medication, by checking it, by working out, by eating a healthy diet. That is how you can control some of these things.
So it's not like, oh, it's in my family, there's just nothing I can do about it, so forget it.
That's correct.
That's great.
Absolutely.
So we have some other questions coming in for you. Now, here's one. This is a pretty interesting one. You had mentioned that now transplant centers are required, and other entities of not looking at race calculations and determining whether somebody is eligible for a transplant, and um, a couple of other things here. What this question is how are healthcare providers being penalized if they are still using the race-based equation?
They're not. And so that is why we're trying to get the information out there that there is a new equation. That new equation was recommended by the American Society of Nephrology and the National Kidney Foundation in 2021. That's when our task force made that decision, September of 2021. And it was the recommendation was for immediate, right, changing the labs to using the new equation without race. And so we know that not everybody has changed it. Why that is the case is, it remains to be discovered. But people are not being penalized, institutions are not being penalized, and so I really am really passionate about getting this information out there so people can know to ask their physician, hey, this is a national recommendation, why has this not been changed? This can be affecting my care. That is how we get things to be changed. Otherwise, this can take for a very long time to get the new equation into laboratories.
So how can people be sure? So can you walk through maybe the process a little bit? You have your kidney function tested with blood test, urine test. You get your results back, and unfortunately, sometimes nobody goes over your results and explains what it means, and you're just left with these numbers. So,
Mm-hmm.
can you walk through the process? What should someone do to make sure that the right calculation is being used? And if it isn't, what should they do about it?
Yeah, so the easy thing for a Black person in particular, because again, this equation, there was one for Black people and one for all other racial groups. So if you're Black and you're seeing Black EGFR African American, sometimes it says, or Black, that's going to be your cue that you haven't changed to the new equation, because there should be no new equation that has a race tagged or tied to it. And so if you see that, print it up, send your physician a note in the portal if you use a portal, or call, and you make sure you talk to that physician or that nurse and say, why am I still seeing this? There's a national recommendation from the two kidney societies that we should not be doing this. And I think everyone should challenge their physician. And the physician needs to answer, right? Because this is, again, a national recommendation that they need to be doing to really be providing the best care for our patients. And why are they not following that?
So do all physicians know about this change? And if they do, is there a period of time that's been given for all institutions to make sure that they're using the right calculation?
I wouldn't say all, right? And I would even say that that applies to a lot of national guidelines. We have constant upgrades or, updates to guidelines about what type of blood pressure control should people have, or diabetes control. And sometimes it takes a while. I think academic medical centers, right? So health centers that are tied to medical schools are the ones to most likely change this. If you live in an area that's not maybe tied to an academic medical center, sometimes it's hard to get those guidelines out in a rural area or a suburb, right? It might be a little bit more difficult. And so that's why I say that it actually needs to be a little bit of self-advocacy. Or, by the way, you can always call your patient advocacy office. If you really feel like you don't have a voice or that you're not being heard, you call your patient advocacy office. That is the team that reports to me currently. And that information gets up to the top very quickly if you're making that type of complaint. If you say, I want to file a complaint, you can use the word discrimination, right? This lab is being used. It has Black race in it. I feel like I'm being discriminated against. Why is my healthcare center or clinic not following national recommendations? Oh, that's going to get to the executives very quickly. So I think first step is that you have a conversation with your nurse, your doctor about this. If you don't get an answer to say that they're going to change it, you can go to your patient advocacy office and make a formal complaint.
Can you talk about patient advocacy offices? Do all hospital systems have those? Is that the name that people should look for? Or are they known by other names?
Yeah, I think if advocacy, maybe if you forget what that's called, just say, I want to file a formal complaint about this. Every clinic and hospital has a way for you to file a complaint. All of those things are reviewed, and all of them actually, based on our national regulations, have to be resolved within 7 days, 14 days, depending on what type of complaint that it is. So I would just say, I want to file a complaint about my care. That will be addressed. Every clinic, every hospital, whether it's called patient advocacy or not, has a way for patients to file a complaint about their care.
Thank you for that. And that's what we try to help people with at American Kidney Fund in terms of, you hear the terms advocating for yourself, and that's what that means. When you have the information and you know what your rights are, there are things that are in place where you can address those, and there are things that you can do about it. So that's really important to mention those things, because sometimes when you're getting care, you're in the middle of dealing with the diagnosis and you're just not really sure what to do. And so having something like that in place can be very important for people.
I agree.
So we have some other questions. Okay. Let's see. One question is, have there been any studies tracking how addressing healthcare inequities has impacted the lifespans of Black kidney patients?
Absolutely, and I'll actually broaden it out to even more broadly, that Black people die sooner than other racial groups in this country. And all of the studies have shown that is directly tied to the social determinants of health, the social differences or inequities that we have. That is what drives earlier death. We have higher rates of disease. We have different access to insurance or less access to insurance. We're living in neighborhoods that are less safe, right? That have less access to grocery stores or even hospitals. We call them healthcare deserts, right? That is what leads to earlier death um, among the Black population in the United States. So for patients with Black kidney disease, that trend follows, right? They have higher rates of diabetes and high blood pressure. The more diseases you have, the less likely you're going to live longer than any other racial group.
So can you talk about just a little bit more about what does it mean, social determinants of health? And what does that mean necessarily in terms of the outcome? So there's this understanding that there are certain things beyond someone's what they're born with and the circumstances under which they live. Can you just talk a little bit more about how does that show up?
Yeah. So again, it's the thing. It's where we live, work, play, and grow. That is a definition of a social determinant of health. Those are the things that directly influence our health. Where you live, how safe is that housing? Can you afford your food? Can you afford your housing? Can you afford insurance? What type of school system? What kind of quality education? That, what is your income? That is tied to your health, not your race, not your ethnicity. That is what is exactly tied to your health.
And you had mentioned it isn't about race that causes disparities, it's racism. And that's what you had in one of your slides. So some of the things you talked about are unfortunately linked to one's income. But what if you are somebody who is Black, Latino, but you're not of higher income? Do these racial disparities still affect you?
Unfortunately, Melanie, yes. And that just goes to show the racial discrimination that occurs among all, regardless of how wealthy you are. We see stories all the time on the news. Football players being accused of something. They're just doing their everyday activities, or some professor who's Black, right, or Hispanic being accused of maybe breaking into their own home. If they're having a hard time opening the door, everybody deals with, not everybody, Black individuals, Hispanic, Native American, Asian, they all deal with racial discrimination regardless of how much income you have or highly educated you are. So if you remember that graph I showed, I didn't really focus on it. It's the social determinants of health plus the stress of just living with daily discrimination, right? Whether it's outright someone calling you some type of racial slur, or whether it's a little bit more subtle, what we call a microaggression, right? People just
Mhm.
doing things that are unfair and unjust to you because of your gender, because of your race. That type of stress causes changes in the body that can affect your organs negatively, that can lead to heart disease and kidney disease.
So what I hear you saying is that regardless of access to healthcare, which that's important, but you can still have access to healthcare. You can still live in an area that's not a food desert and have access to adequate food and high quality food. But having the experiences of racism over a period of time can cause a load of stress in the body that can affect your health overall.
Absolutely. 100%. I think a highlighted area of disease that's really made national news is maternal health, right? Uh, the the tennis player, I'm blanking on her name, but she was delivering a baby.
Oh, Serena Williams.
Serena Williams, that's what it is.
Hmm.
Thank you.
Hmm.
She was delivering a baby. She's a celebrity, plenty of money, right? And she was discriminated against. She was not listened to. Her complaints were not taken seriously. And she actually ended up having a blood clot. Why did that happen? You hear about that stuff all the time, of people not being listened to, or they're just being dismissed as being dramatic, or maybe that they're looking for pain medications because they're Black or Hispanic and they don't really have pain, because there have been studies that have shown that some doctors feel that Black people have thicker skin. So their pain, they can take more pain than everybody else. That's the type of racism that I'm talking about, that people face all the time, regardless of how much income or education or neighborhood you live in.
So it isn't just maternal health. It affects kidney disease too. It can be so many different aspects of the healthcare system that people can encounter these unfortunate experiences.
Absolutely.
So let me ask you about clinical trials.
Mhm.
Now, I've heard more about encouraging people of different racial backgrounds to participate in clinical trials. Can you talk about the importance of Black people participating in clinical trials, what kind of barriers there might be, and what people should be doing about them?
I think clinical trials are so important. And, I didn't really do a deep dive into the research study about EGFR equations. But one of the challenges of the first study that came up with that Black EGFR equation was that there was just a very small amount of Black people. So they're making very big decisions based on a very limited number of Black people. Just imagine if that study had 50%, that study actually had 12% Black people in the trial population. Imagine if it had been 50 or even 75, we wouldn't be in this situation. So they made a decision based on a very small amount of Black people. Who knows? Maybe all those Black people came from the same neighborhood, right? Like it's not right to do that. And so we need more diversity in clinical trials to just basically demonstrate that Black people are not all the same. We come from different neighborhoods, we eat different foods, we have different types of education, we have different types of income. You need that type of diversity, not only with Black people, with all people. But in particular, Black people have been treated so poorly and continue to be treated so poorly that there's a fear of, I'm going to be experimented on. They're going to, withhold things from me. We have what happened with the Tuskegee experiment, right? Where men who had syphilis were just, that medication that was used to treat syphilis was withheld, and they ended up having terrible, terrible outcomes from that, right? Different types of issues happen. And the researchers just really wanted to see what happens if we don't treat syphilis, right? And all of these terrible things happened to these Black men in Tuskegee. So that didn't happen that long ago, right? So people were alive, people are still alive. They lived through that. So imagine what you're telling your family, right? Like how traumatizing that is, that you experienced that, you lived through that. You may have known somebody in the Tuskegee study. And so there's this kind of notion, it was perpetuated during COVID. I'm not going to get tested and I'm not going to get the vaccine. I mean, they're going to try to, hurt Black people like they hurt in the Tuskegee experiment. But we really need to have healing and education in our community so that we can participate in research. We deserve to be in these research studies, right? We deserve to have a voice. We deserve to say, like, you shouldn't be doing this. You shouldn't be making these type of assumptions. Imagine if we had that in this EGFR study, people who were like, well, kind of informed about research and kind of what they were doing. Imagine having that voice in the study, because you can have a voice. Well, why are
Mhm.
you doing this? What's going on? Can you tell me more in that consent form? How is this going to benefit me? What are some of the harms? And then researchers have an obligation now more and more to go back to those clinical trial populations or their research participants and tell them what they found and explain that in a way that's easy to understand. So things have changed over the years. We now have regulations where people can't do the Tuskegee experiment again. That is against the law. So those things won't happen anymore, but there's still this fear and mistrust, and rightfully so. But we need to move forward with information and healing and really be advocates for ourselves in these research studies so the next generation doesn't have what we have with this EGFR equation affecting so many people, thousands, millions of Black individuals for 20 years were affected because partially because of the diversity of that clinical trial.
So talking about the researchers, we talked about patients and what patients can do and what patients should be looking out for. But all the onus is not on the patient. So what kind of training is happening now for, let's say, medical students, or what kind of training is required for current physicians who, it's called unconscious bias for a reason. Sometimes people just aren't even aware that they have these biases, or that some of these social determinants of health even exist. So how are our providers being trained so that we can also reduce these types of experiences?
Yeah, Melanie. So I'll tell you, I'm really excited about the curriculums that are changing in medical schools. Even this EGFR controversy, right? It got so much attention in the media, Grey's Anatomy, the doctors did a special on that. I was on the doctor's show. So many people heard about this that the medical students who would this change would not have happened with medical students. They were outraged. They went to their medical schools and said, this is wrong. So now they're changing curriculums that used to say, oh, Black people have more strokes because they're Black, or Black people have more kidney disease because they're Black. They're now changing it to inform the new students or the younger generations that that's not true, actually. It's structural racism, it's differences in social determinants of health, it's racial discrimination. So I'm really excited. And while I will say I'm very excited about the younger doctors, they keep me energized. It's a little bit different with some older doctors. And so I know some people don't feel comfortable maybe seeing a doctor that's younger than you, but guess what? That younger doctor is more likely to be able to practice medicine in the way that I've described rather than someone who studied that curriculum a long time ago, right? And may still have these kind of outdated beliefs about Black people and race and Hispanic individuals. And so I am encouraged that curriculums are changing. I get called all the time about my opinion, my review of different medical curriculums, and that's happening in nursing schools, social work. All of the curriculums are changing. So I think that that's going to really be great for the future care of our patients.
So what about a provider who's been practicing for several years, and maybe things have changed in terms of the EGFR or other standards of care? Are physicians who have been practicing for a while, are they being provided with some of these new guidelines and regulations so that things are staying current?
Yeah, again, we have national recommendations. And so that's out there for everybody. Again, some people are going to hear about it and adopt it more quickly than others. But that information is out there. But it's just, when you're out of medical school, you receive your information a little bit differently. So you do have to put it upon yourself to take the certification test to keep you board certified. Those questions, I actually am doing my board certification test in nephrology, and I saw this race and EGFR equation come up, and I was so happy. So that is now a question that's being incorporated into test, right? For the older physicians that are not getting the curriculums that younger medical students are getting, or residents and fellows, but they do have to stay board certified, and to pass that test, you have to get the answer right. So it's out there.
Okay, so that's good to know.
Yeah.
So a question about the EGFR calculation. You mentioned that that's been a recent development. What if someone prior to, was it 2022, 21, when that changed? What if someone received a diagnosis and a calculation prior to that? Because it wasn't that long ago. Should they have their calculation done over again, or was there some automatic recalculation that was done without anybody being told in terms of their medical records?
Yeah, there was an automatic recalculation. So no one should have to calculate anything by themselves. It's just going to appear in your labs once you get those labs that look at your kidney function. So that will be that's an automatic change if your clinic or lab has, again, changed the equation. That has to be on the clinic or the hospital or the lab that you get your care at.
So if you had a diagnosis prior to the change, should you have it done again just to be sure?
Yeah, I would encourage everyone. I wouldn't go before your annual visit. You don't want to be charged, for something. So you should definitely call your insurance and make sure that you're due for your visit. But when you are going for your checkups, to make sure that is a question that you ask your physician or your nurse about, because again, they may or may not have heard about it. And then when you look at your labs after your visit, then you can verify whether that change has happened or not.
Okay, so we have one more question. I think it's have time for that. If we can do it quickly. One question is, what recommendations do you have for those listening on what they can do proactively to start addressing disparities in their communities?
Yeah, I would say like knowledge is power, right? So some of this information may be new for some people, and some of it you've heard before. But tell a friend, tell a friend, and tell a friend. Tell your family members. If you're involved in community organizations, whether that's a spiritual organization or even any other type of social groups, advocacy groups, talk to them. Bring this to them, right? We have health screens that we do at my institution where we try to bring this information forward to the community. I know churches have done a lot of education in the Black community. So knowledge is power. And eventually this will become mainstream. We won't have to worry about getting it out there anymore, right? It will just be the normal thing that happens. But we're not there yet. Even 3 years after this recommendation has come out, we're not there yet. So I think we need to keep having these conversations, going to your organizations. You can easily find printed materials online if you Google it about this change in plain language. Bring that to your organizations. Have a health fair, right? Have an afternoon or a morning or all day session where your job is just to get the word out there and bring that back to your community.
Thank you. And I'll also mention on our website, American Kidney Fund, we started a whole initiative that we launched back in 2021 called Kidney Health for All, where we're looking at addressing disparities in 4 areas of kidney disease, in particular, the racial disparities around prevention and awareness, clinical trials, home dialysis, and access to transplant. And if you go on that site, kidneyhealthforall.org, you can find a lot of different resources in terms of not only those 4 areas that I mentioned, but also different legislation that our government affairs team, they're working on, where you can add your voice and contact your local legislator. So there's another way. Well, I think we're coming at time, but before we wrap up for the day, one, I want to thank you for all of the great information that you provided, practical information, things that people should know, things that people can do. So this is how we like to wrap up all of our sessions. Dr. Ananya, if there are 2 things that you can mention, one, what out of everything that you mentioned, if there's only one thing people should know, what is that one thing people should know? And then what's the one thing that you think people need to do?
Yeah, I think the one thing that people need to know is that you are worth you are worth all of the efforts, right? You deserve the best health. Everybody deserves the best health, no matter where you're coming from, no matter where you live, right? No matter what kind of doctor you're seeing, you deserve the very best healthcare. Don't let anyone tell you that you don't because you're a certain gender or race or ethnicity or you speak a certain language. You deserve the best. That's number one. Number two, what can we do? All I would say is that you advocate for yourself, right? No one will care more about your body than you. Even if you're best friends with your doctor, that person will not care more about your health than you do. So that is what I would ask everyone to do, is to advocate, to take care of yourself, to take control. You have the power to be able to change certain things, even if you have certain diseases that you're living with. You have the power to take control of your destiny. So I would encourage everybody to do that. Stay informed, ask questions. Don't be afraid to ask questions. You will never be penalized. You'll never be punished for asking questions. If you don't understand, ask that question. And that's what I would say people should do.
Love that. You deserve best care and ask questions. So again, thank you so much for all of the wonderful information that you have. This session's also recorded. And please stay with us because our next session coming up about right now at 11 o'clock is patient-centered approach to kidney health prevention and wellness. So stay tuned for some really good information there. Thank you so much again, Dr. Nanya.
Thank you for having me.
And thank you all for joining us.
Bye.
Bye-bye.